base of hospital claims, hospital utilization. And we had data for the period 1998 through 2004. And when we looked at both total hospitalization costs and also costs for what we term potentially avoidable hospitalizations, those for what are termed ambulatory care sensitive conditions, or ACS conditions. These include everything from pneumonia to congestive heart failure. ACS hospitalizations account for about 30% of all hospitalizations. And we only looked at those long stay hospitalizations. And the reason for this, of course, is that Medicare pays for short stay post-acute nursing home services. Medicaid pays for those long stay nursing home care. And so what we wanted to do here was really isolate the Medicaid costs, Medicaid covered nursing home services, and look at what was the hospitalization of Medicaid patients. Long stay, so we define long stayers here as 120 days. Here are the costs. This is an aggregate, all of this in 2004 dollars. You can see, once again, this is just for one state. These are just the hospitalization costs. These aren't physician costs, none of the transportation's in this, just the hospitalization costs. You can see that in 1999, in New York State, the cost of hospitalizations for long stay nursing home residents was $750 million. And for those ACS conditions, it was $209 million. Over the course of our study between 99 and 2004, there was a 29% increase in total costs, so we're almost up to $1 billion by 2004 for total costs, and up to $224 million for those ACS conditions. So a big number. Now the first thing is take that $224 million. Who's footing the bill for that? That's really the key issue, right? We know that Medicaid's largely paying for nursing home services. Who's bearing the cost of that, of those hospitalization expenditures? Not surprisingly, it's largely Medicare. And so if you're going to do something to prevent hospitalizations, Medicaid's largely funding nursing home services. Medicare's largely reaping the benefits. Here you can see Medicare is a primary payer. Unfortunately, with the Sparks, we weren't able to break out the exact numbers across payers. We were only able to break this out by primary payer. Medicare is a primary payer for 84% of the total ACS costs, while Medicaid only accounts for 12%, others 4%. So does New York State Medicaid have a strong incentive to introduce policies to decrease hospitalizations? Not really, Medicare does. And actually the reason we got involved in this project in New York State was to try to engage the feds, to take them these kinds of numbers and show them that there's some sort of partnership possibility here where New York invests in infrastructure, that saves the feds money, saves CMS, they then give some of that money back to New York. It never got anywhere, but I want to talk, anyone that knows state government and CMS probably could have said, I could have told you that 2 years ago. But what's exciting, we did get some neat research out of it, obviously, which was great. But it also helped, I think, set some of the data up for the pay for performance demonstration. I'll talk a little bit more about that because that's really kind of building on the sorts of ideas we were putting forward as part of this project. That was going on separate. I'm not trying to say that we were a building block, but I think some of our data was at least helpful in framing some of those issues for them. So the bottom line here is pretty simple. Medicaid pays for roughly 80% of nursing home services in New York State. So they're the dominant payer. They pay a relatively small fraction of hospitalization costs. So there's really less incentive for Medicaid to adopt policies that encourage nursing homes to decrease these unnecessary hospitalizations for ambulatory care sensitive conditions. And I'd like to talk about two sets of policies that we have analyzed that Medicaid might adopt, two Medicaid payment policies that may influence hospitalization rates. The first are termed bed hold, and the second are just the Medicaid per diem. So bed hold is a policy it's a payment basically that states make to ensure that when an individual is hospitalized, the nursing home will hold that empty bed for them while they're in the hospital, so that they have a bed to come back to. The goal of the policy is to sort of ensure continuity of care. We don't want individuals hopping nursing homes, and we definitely don't want nursing homes kind of shoving difficult patients out the door when they're hospitalized, or even sending them to the hospital so that we don't have to have them back. We can think of a lot of perverse incentives. So bed hold is supposed to encourage continuity. We have a companion paper to what I'll present today that shows that it does, bed hold most definitely does encourage some continuity, and Marion was talking about some work she's done here in Florida that definitely shows that as well, that these policies certainly do help in terms of that continuity of care. However, what we're arguing here is when facilities are being paid this amount to hold an empty bed, they create an empty bed, right? It's easier to have an empty bed than to care for a resident. And so it's a double cost here. Medicare pays in the form of the hospitalization, Medicaid pays with the bed hold payment. And so what we wanted to look at in this project is whether the states with a bed hold, those 36 states that had a bed hold, did they have different hospitalization rates than those states without a bed hold policy? The second policy is a little more straightforward. It's just the average per diem that the state pays nursing homes. So what's the average payment rate? And this was part of that study, the state map that I put up earlier that we published in 2007 in HSR. And once again, we just looked at these payment rates and bed hold policies and their relationship with long-stay nursing home hospitalizations. So those Medicaid hospitalizations were excluding Medicare short-stay hospitalizations. This is a national study. We're not using the Sparks here. We're using the merged Medicare hospital claims and the MDS once again for just the year 2000. The results were really eye-opening. We controlled for a lot of measures at the patient, facility, even at the market level and other state-level factors. And what we found was that a $10 increase in Medicaid payment was associated with a 5% lower odds of hospitalization. Now I know if you begin to do the back of the envelope math, $10 for every patient for every day in every nursing home begins to sort of add up, but that's a pretty strong relationship that for each additional $10 that's paid a nursing home, there's a 5% lower odds of hospitalization. The second result really kind of blew us away. The presence of a bed hold was associated with a 36% higher odds of hospitalization. Once again, when you pay for an empty bed, you get an empty bed. It's pretty simple. And what we argued is that Medicaid programs really, because they don't bear the cost of these Medicare hospitalizations, they do obviously bear some bed hold payment, but they bear a much lower cost in terms of the hospitalization itself, have less incentive to increase nursing home payment rates, less incentive to repeal bed hold, because they don't share in the savings downstream from the decrease in hospitalizations. So as I said, I do want to come back to that issue with pay for performance in a little bit, sort of talk about how we could strategically address this disconnect between nursing homes and hospitals in terms of the high rates of inappropriate hospitalizations. Yes. You know, it's interesting. And Mary and I sort of had some back and forth on this last night, but it's hard to take the two. So when we take them in conjunction with one another, and we've sort of done a back of the envelope, and that paper's I think now out in HSR late last year. So it was a follow-up to our first bed hold, and it was basically about continuity of care. Orna Intrator once again is the lead author, and what we found is that yes, it did encourage continuity of care, but those gains from that sort of continuity were pretty small relative to this strong increase to hospitalize in the amount that Medicare is spending on the hospitalizations. So we felt that sort of the damage that bed holds did in the form of higher hospitalizations and the costs, with the health costs along with the financial costs of the bed hold payment plus the hospitalization costs more than swamped the gains from sort of any continuity of care. We showed that the continuity was stronger, but it wasn't overwhelmingly. And I'll note as a final point on that, these bed hold was enacted in a time when occupancy rates were up above 95% nationally. And so it was a way of ensuring that those homes in markets that were with excess demand, with very very high occupancy, that bed would still be there. I'm not certain though that in today's market with much lower occupancies, with lots of competition from assisted living, if bed hold is really an outdated policy. It's kind of a policy geared for 20 years ago rather than a policy for today. So I have a lot of concerns about And it's clear that there are some very good homes that are still at a very high occupancy. There's some states, some markets that have higher occupancy. But by and large, occupancy is now around 85, 87% nationally, where it was once above 95%. And I'll make one final, I just said I had